With me is Howard Quayle, and 10% reduction in hospital waiting times is the big announcement, one of them you're making here today. Can we break this down? Because I always get worried when I see that, because obviously it's not across the board, is it?
No, it's not. It's outpatients going into Noble's Hospital. So
all outpatients or certain selective procedures, surely?
Well, across the board, a 10% reduction. Some have gone up, sadly, and some have gone down. So, for example, the pain clinic, I'm not happy with our waiting lists there, and that'll be an area where we need to. So, you know, that's a target area I've asked the officers to work on over the next 12 months. But overall, across the board, there has been a reduction in 10%, over 700 people less waiting. And
what's caused that? You've got more men at the front line, or what?
No, it's a new management structure looking at increased efficiencies. We haven't.
So the same people, seeing more people?
Different people.
Yeah.
And yes, and the same people. Different ways of doing things. And we have the health inspection fund of over 4 million, but that doesn't enable us to throw money at waiting lists, because we can't use that money for regular increased officers. So you look at maybe a new piece of equipment, and that new piece of equipment might enable the new endoscopy suite that we're working on at the moment.
What about the blitz of getting people in, you know, short term and clearing the backlogs? Is that still for other purposes within the hospital? Are you still using that as a means to get your numbers down?
Well, I'm looking more at telemedicine, for example. If you look at dermatology, at the moment we were bringing...
Is this remote control, sort of remote medicine,
you bring over a top consultant, and he is over for a certain period of time, and he gets to see all sorts of cases. If we have someone with an interest in dermatology, they could deal with an awful lot more people. And if people come to them with severe cases that they're just not... they're not an expert in, they can then dial up on the phone and speak with the screen with the patient there to an expert in the field, who can then look at that condition and say, no, you better send them to me, or try this as a treatment. I've seen this before. And by doing that, we can get greater use of it. We're not paying a top expert to fly over to the island. We can only pick them up for so many times in the year. So we can see a greater number of people, but at a far cheaper rate. And those are the sort of examples going forward where we should be able to reduce the waiting list without throwing money at it, because we haven't got the money to throw at it.
What's the average time now for a waiting list?
Well,
if I get on one of them, what would happen?
50% of people in outpatients are seen within 2 months. But there are certain areas, hip and knee operations and the pain clinic, where I don't think we're good enough. We're going in the right direction across the board, but there are areas that we must improve on. So I don't want the public to think, well, we've achieved 10% waiting, he's going to switch off. I can assure the people of the Isle of Man that we are constantly looking at improving this. But please remember, within 12 months, we've got a virtually entirely new management team in place. We've had 4 inspections by the West Midlands Quality Review Service. We've got an awful lot going on, and we've still managed in that short period of time to reduce by 10% the waiting list.
Well, we're up to those reviews. One was put back, wasn't it?
Well, what's happened, we've had a 6-month gap, which was agreed with the West Midlands Quality Review.
Why do you need that?
Well, because we only have the same team as we had before, and they were review after review after review, which takes an awful lot of time, and there was no gap to give them then the chance to say, right, we've had these reviews, let's start to implement the recommendations that have been brought forward by the West Midlands Quality Review. So we've had a 6-month gap where we've set up a board to review and start to put in place the changes that the West Midlands Quality team...
And those changes, are they coming
in? Yes, they're coming in now, and we're back having the reviews again. I think we start in the middle of October. We're looking at sort of children's health in general, whether it be mental health or maternity.
Talking about waiting lists, if someone's got cancer, and in the UK there's been a lot of this about now speeding things up, getting straight to a specialist. Is that the same sort of track you're taking?
Yeah, we have the same number of weeks from when they're referred to. So it is a fast track. And again, Paul, the problem is the health service will never have enough money for delivering these services. We have to make sure that what money we do have is spent in the best places.
Are you relaxed, or are you comfortable with the way things are going here? In general, or, you know, I mean...
I genuinely believe that the health service of 14 months ago and the health service now is where we are going in the right direction. I've constantly said to people since being appointed, this isn't a quick fix department. It's a 3 to 5 year period of improving the changes. And cancer is another area where we're looking at trying to get extra funding in. We'll be coming to Tynwald looking for a capital project to extend an area shortly, but you know, I'll be topping out a topping out ceremony for the new endoscopy suite. The breast care unit is all on track. It's a constant work in progress.
Finally, there's this talk we're hearing on social media, particularly that you're going to close a ward in the summer. Can you liken this? Is this a fact, and what is it?
Well, it's not a fact. It's something we're looking at, and it should be a good.
So you might be closing.
We might be closing Ward 20, and
which does.
It looks after elderly patients. 8 of the beds are for stroke rehabilitation. So Ward 7 looks after stroke patients, and when they get to a certain level, they're then moved into Ward 20, where they undergo a process of rehabilitation before they can go home.
So you might close it
because we have 22 beds in Ward 20, and as of today, there's only 11 occupied. We have spare bed capacity in Wards 5, 6 and 7. Ward 7 looks after the stroke. So basically, Paul, if in the summertime our staff are wanting to go on holiday, we're having to bring in agency staff to fill the gaps whilst they're on holiday. We have spare beds, and this has been a historic problem, but the new management have looked at it and said, right, if we close Ward 20 for 4 months and move the patients into Wards 5, 6 and 7, the staff can then be transferred into the hospital, and we're looking at a potential saving of 250,000 for that 4-month period.
And you're saying 4 months, so you are putting a time limit on it? It's not a closure indefinitely?
It's not a closure indefinite. This is just looking at saying, we spend X amount of money at Nobles Hospital, about £90 million. I've got to make savings, I've got to improve services, I've got wage negotiations, I've got a £120 million wage bill, 1% increase on 120 million is 1.2 million. We, as a department, have got to constantly be looking at improving our service and trying to be as innovative and make the savings as much as possible.
When you say it's not confirmed, when will you make a decision on it? Is it down to debate with...
It's not down to me politically, it is down to the hospital management team. What happens is they've looked at these proposals, and instead of just year on having wards with half occupancy and stretched with members on holiday, it seems as a logical approach. When they're convinced that this is the right move and they've discussed it with the staff, then we'll be making a full announcement.